Thank you, AIOS, for having given me this opportunity to speak, and I feel honored. And I'd like to talk about the revolution we've undergone in Retina, and especially in India, because it's important for us for our own motherland. And one thing in 15 minutes I possibly can't cover all the revolution, but I'll go to stick to one medical and one surgical revolution. One thing which has gone under a major sea change is the imaging which we were doing and what we are doing now, and what probably the future will we will be doing. So the last 2 decades has seen a whole lot of you know changes. So you have this now introduction of autofluorescent imaging in which you actually don't take any. It's non-invasive test, and it's the lipofuscin in the pigment which is present, and that gets hyper autofluorescent in cases where there's some kind of a choroiditis like serpiginous choroiditis or any kind. So that can show up as a hyper autofluorescent, and the healing part can be a hypo autofluorescent. So there's no dye. It's basically the fluorescence from the inherent fluorescence from the lipofuscin. Same way in other cases of disseminated or serpiginous severe type, you can see a marked, you can see the left eye that there's been a very good resolution of the choroiditis with a very little bit of activity left, and so the patient's doing well. And you can do fluorescein, but the fluorescein generally not required. So we're moving away from invasive to non-invasive. Previous 20 years back, we were doing always invasive tests like fluorescein angiography. Same with inherited retinal disorders. There are so many of them. It's no longer called HMD. It's called inherited retinal disorders or dystrophies, and you can see a bilateral symmetrical coin-shaped lesion, which is quite classical of one of the cone dystrophies or the Stargardts. So the fluorescein which was in the 1960s, Novotny and Alvis, you all know the two medical students in Russia who thought of using fluorescein as a dye to image just like you do a carotid angiography, coronary angiography, image the retina, and they could see a whole lot of new findings, and the choroidal vessels were not studied. There was a little bit of iris angiography. There was oral fluorescein also for young children or patients who developed anaphylactic reaction. But basically, it was a one fluorescein angiography which left people absolutely, amazed to see the changes which you can see in a diabetic retinopathy patient. But ETDRS basically used fluorescein angiography. ETDRS was a very important study done for the early treatment diabetic retinopathy study, to study the role of aspirin, to study the role of focal grid laser, to study the role of scatter laser. So they used fluorescein angiography basically. So they never had anything else. No OCT, no OCTA, no other autofluorescence. This is basically fluorescein angiography. So this is the way everybody does it, and this is the way it was being done 20 years back also. This is the anticoagulant vein we were taking and inject fast, because if you inject fast as a rapid bolus, you can get a very good contrast. So preferably use the 20% dye 3 cc or the 10% 5 cc, with the contrast is a little less. And the dye exits very fast. In less than 5-10 seconds, the dye is exited. In fact, the late phase is at 5 minutes. So you have to take pictures very quickly. I remember in our early days when we were residents and assistant professors, we were take pictures very quickly, and sometimes you miss a shot. So you get a film coming out, film-based fluorescein cameras. So the digital came later. The film-based was the reel was taken out and then processed for the pictures. So you could never view the pictures so well. You could just take pictures. You couldn't improve the pictures. There's no tools to enhance the picture, and you could not retrieve the pictures. So there was a big problem with the camera-based systems. Then the digital systems came in where you did not need any reels, and you threw away all the color picture reels and the black and white reels. The 400 ASA or 400 ASA films were used for high-speed fluorescein angiography, and the 100 was used for color pictures. So that was the way things were very cumbersome, because you collected a whole lot of reels at the end of the day when you were doing fluorescein angiography. So of course, patient experienced nausea very commonly, which is the most common side effect. But usually they used to get vomiting if they're for full. So we used to advise them very strictly that they come with collars open, no tie, and also to not eat so much, have a light food, and also that bring a attendant along. So we used to keep an emergency tray. So as it went along, the imaging became more advanced, and with the present day you usually get a wide field imaging. So of course the standard 30, 50, 50 degrees, 55 degrees does suffice. You can take montages, periphery, but sometimes the diet does exit. So what is seen actually gets treated. So initial phases and mid phases may get missed if you take a montage, but may not get missed. So it's actually not a necessary to have a wide field imaging, but you can get a pole to pole, near pole. It's not 200-degree approximately. So you can do a OCT along with its multimodal imaging. So the Diabetic Retinopathy Clinical Research Network defined by wide field imaging as greater than 100 degrees. The ultra wide field was going up to 200. Disadvantage of this Heidelberg system, you can see the fluorescein was so well been there for ages. So this is the last 20 years we've seen fluorescein come, and it's staying on, and probably will stay on for quite some time to come, because it's something which cannot be replaced, because you get a lot of information when you do a fluorescein-graphy. Though things are hyped out of, OCTA has come in now, and everybody's comparing fluorescein with OCTA, but still fluorescein has a role as a baseline indicator of the disease, and also for follow-ups after 3 to 6 months. You can see the effect of laser, the effect of anti-VEGFs, and I often like to do the laser, and in such cases, and would see the effect of the laser, how much of ischemia is still left. You can titrate your laser. You don't go blindly. So the healthy retina should not be lasered. Along with that, you can see the color picture and the OCT. So as time went along, the OCT also started coming in, and the OCT was a spectral domain OCT initially, and you can see two color pictures of the same patient, and he had actually a young male, and he had moderately affected vision 624 ODOS, and he had extinct retinoschisis in the center, which is like a honeycombing, and which looked just like as if there was a CME. But if you see, the OCT actually told us that it was a case of extinct foveoschisis, because the acquired retinoschisis is different, where you have autoplexiform layer, or typical in the autoplexiform layer, the reticular and the nerve fiber layer. The X-linked is that was autism dominant, the acquired one, but this the X-linked is a juvenile one, which actually people say you can do surgery and all, but I don't think you should do anything for that. It just give the best correction to the patient. The other day, just a week back, we had a young girl. So I just put this picture in this talk, which Partha so gratefully told me to deliver. So our prolonged dark adaptation, Mizuho Nakamura phenomena was positive. This is Oguchi's disease. It's got an autosomal recessive inheritance, and you get a kind of a abnormal sheen from the retina. So this is very well known, very commonly seen in Japan. Probably commonly in the sense that they have more of this genetic problem, and we don't have this much. So vision is very good. So the dark adaptation is good. We do a dark, the ERG in the dark and the ERG in the light. So the dark adapted ERG was markedly affected. It was nearly flat in this girl, because there's no treatment as such. So also ICG came in with the TAP study came into the 90s, 2000s, and the TAP study and the VIP study was for ARMD, and they realized that fluorescein was there, but then ICG slowly started coming in, because they realized that things like RAP and all could not be picked up. So RAP was already identified in the early stages. PCV also started getting identified. So when they realized these two entities were there, and there was a subretinal hemorrhage component also sometimes, which couldn't be visualized beyond it. So they realized in the initial AMD studies from the US, most of things have emanated from the US. And in a way, it's good, because they do a lot of good research and good clinical research and authentic research, and there's no cooking up of data or anything. And so we believe them. The DRCA.net trials are also quite good, but of course, sometimes the industry driven, so you have to be a little careful. This is the case of ICG angiography, and you can see the polyps, huge grape-like polyps. The case of a PEHCR, peripheral exudative hemorrhagic chororetinopathy, where there's it's a peripheral form of PCV. So then, of course, the OCT has improved over the years, and from the days when we did only fluorescein angiography and told the patient that this is your proper diagnosis. We now have multimodal imaging. We can at least do a OCT. The OCT gives you a whole lot of information about the macula, and it really tells you about patients of AMD, also patients of DME, patients of any kind of macular edema for repeat injections. So often combined with OCTA, it gives you a very useful tool for non-invasive testing. So people started moving away from the revolution was from more uh, uh, higher magnification, higher resolution imaging to also non-invasive procedures. So OCT people like, and it's a workflow is fast. You're getting a OCT, the workflow is very fast. But fluorescein, it takes time. Because you've got to prepare the patient, keep the sister ready, keep the emergency tray ready. We've seen patients collapsing while they're getting the fluorescein just when they inject it. So you have to keep a whole thing ready, and in case they vomit and all, it can be a lot of problems. So the biggest advantage of this is a laser, which is not a superluminescent diode light. So it's a laser, and it can image the entire retina, and you can see the subretinal bleed with the polyps, with the PED, the multiple PED, and there's no sensitivity roll-offs, longer wavelength, so you can see, I get very high resolution, and the entire vitreoretinal interface to the choroid can be seen. So one thing very important was with the advent of the spectral domain and the spectral society, Europeans, Giovanni Storenghi, and the Americans also started recognizing that the retina had to be divided into various zones, and they were very fortunate to have started understanding the various bands and two-dimensional bands and zones which they found. The ILM, which is the thin band, and then you have the ellipsoid zone, which is actually the outer inner photoreceptor junction, which is the most important. All the studies now say, present day knowledge, that it correlates visual recovery in DME, RD, ERM, ARMD, RVO, CSE. There's one thing missing: macular hole. Macular hole, also patients who close do not recover vision because their ellipsoid is still disrupted, and that takes time to get continuous. So it's a discontinuous. So all these things are important. So people started understanding, and the choroid also they started understanding what is pachychoroid and all. So won't go into details. So this is a patient with a little pigmentation and little pale temporal side, and this was a case of macular telangiectasia where there were secondary neovascularization, which was picked up on the OCTA. So you don't need a fluorescein that time, because sometimes the fluorescein the high flow lesions get picked up very well on OCTA. So OCT angiography is an option to fluorescein angiography. So you can compare the two. So on the color picture on the OCTA and on the OCT, you can see the loss of tissue, which is actually neurodegeneration, neurosensory atrophy, the macular atrophy, and there's loss of tissue, and you can have only the ILM with the ILM brave sign and the CNV. The CNV is over here. So it's the same. So I actually follow the patient with the anti-VEGF and then just get his OCT and OCT. That's all. We don't need a fluorescein. So same way with the strepsils OCT can be imaged all the way in high myopes, which you see a lot of them. I don't know why. But we do a lot of macular high myopic surgery with or without MTM and with or without macular hole. You see this choroid is totally absent. It's literally the sclera. Little bit of choroid is there. The choroidal cavitation is there. And this is a dome-shaped macula, which is not at the fovea, but it's extra foveal dome-shaped macula. All these findings have been described by a number of authors in the West very nicely. So you can always see them up if the residents are listening to it, or for us people also. So there are huge elevated lesions, reddish colored mounts, choroidal hemangiomas, and you can see the retina is lifted up. So all this imaging has undergone. Even the ultrasound is coming. Ultrasound was there for since a long time, but I think the ultrasound has not changed much. But we are also doing the UVM now for anterior PVR. But still, the USG plays a role. So I think fluorescein and USG have not been thrown overboard or into the dustbin. The ones which were there 20 years back, the USG and the fluorescein still stay. It's only that we've added on some tests. And we probably have reduced those tests which were there before, but the fluorescein still has a major role. And this is another patient who was a very healthy. He came to me. He's actually a gym instructor, and he was having blurred vision in one eye. So it was inferior field effect, and there was deep capillary plexus because of segmentation on the OCTA. And once you do segmentation, you find the deep capillary plexus, loss of capillary network. And also on the FA, the capillary network loss, there was a hyperreflective and the middle layers, the paracute, paracentral acute middle maculopathy, and which is there with patients. You don't know why it happens, but prognosis is guarded and it may be an underlying vasculopathy. This is the last week, 2 weeks back, we saw a patient in Ludhiana and having a COVID exposure. His mother had severe COVID and she finally expired. He looked after his mother and he said that his vision started dropping and he had this petaloid appearance in the center and his ellipsoid was disrupted. He had vision was affected. Thinking of in terms of acute macular neuroretinitis, a deeper form of PAM, which is AMN, or is symptom of a retinal epitheliitis. Discussed with my CE residents, so they also felt the same. So went back and read it. It's well the Krill's disease or AMN. But this is a thing which can confuse CSR. You get multiple broad-like lesions. So fluorescein plays a big role. So fluorescein C over here tells you that the kind of leakage is not akin to that of a CSR leak where you have a smokestack and ink blot, maybe one or two leaks, but not this kind of a white dot syndromes. You know, this is a multiple. This is a BKH syndrome, Bokanagi-Harada syndrome. It comes into the broad category of uveo-meningeal syndromes, where neck stiffness, and there's serious detachment over here. And these typical serious detachment, the OCT shows septate. So what you do is you do a fluorescein, you do color picture, you do a OCT, you do, and you get the diagnosis straight in front of you before the patient says anything else. So you can discuss the reports and quickly in the next 5 minutes. The workflow is very fast. Post fluorescein, I tell you, 3 of these tests are non-invasive. Fluorescein was done to basically highlight the initial changes of leakage. But the septate detachment is very classical. It's pathognomonic, a septate retinal detachment is pathognomonic of a leakage. So this is another OCT, which tells you about the DME, very chronic, with the ORTs there and which hyperreflective foci, which are biomarkers. A certain amount of drill also. We lost the inner segment differentiation has been lost. So everything's there, and so the patient has a little bit of a guarded prognosis. The whole neurodegeneration, retinal involvement or macular involvement in DME is not only Novartis saying that you give anti-VEGF, but it is also neurodegeneration. So we have no role of giving actually anti-VEGF because the vision will not improve. Even the patient's macula is not improved. So we have to do what we think is right. Industry does what they think is right. They may say that you get the brolucizumab as the first line. I will say take brolucizumab in those cases where it is not where it is not responding to the classical 3 anti-VEGFs. Only then, when you're dead sure, and then also you discuss with the patient, there's a 4% incidence of vitreous inflammation, there's a 1% incidence of retinal vein occlusion, and then are you ready to take that risk? If you are, then you better sign so that I don't go to court with you and fight the case with you. So only then I'll give you brolucizumab. So it's very difficult to go to attend a symposium purely on brolucizumab, which are happening all over the country, because you can't push I can't be pushed. I'll do what I feel like. So what is good for the patient, and I'll probably do what is good for the patient. So I'm still a little hesitant to give brolucizumab. I've not given the single one yet. So I'm not very, I have no knowledge of brolucizumab, but I give a lot of Avastin. I give a lot of Ozurdex. I give, we have Lucentis or Eccentrix, which is the same thing, and we give Oilia. So I have these 4 in my armamentarium, and this is how you. So OCTA, actually is a very good non-invasive test, and it's motion of the RBCs. So it's a very good, as David Huang first said. And so you've got various, algorithms, and you can follow any of those algorithms. David Huang was the SSADA, and there have been subsequently many other. So you get multiple segmentation of the superficial deeper retina. You can get the outer retina, and you get the RP, and you can get subretinal. So it goes up to the superficial choroid. It doesn't go beyond it, but OCTA is quite useful. I feel even I re-inject based on OCTA, but only in patients who have some ability to improve on FA. If there is scarring or if there is a presence of severe drill and the patient has lost his macula, in the sense macular atrophy has set in, I absolutely refuse the injection. Because once macular atrophy started setting it, probably I'll increase his macular atrophy by giving an injection. And that's the situation. So I'll just finish fast. This is how a fluorescein will look like, and this is how an Octa will look like. So the Octa tells you a little bit same as the OCT. And the modern vitreous surgery, vitreous surgery was Robert McMahon who first used it as a egg and airplane drill in 1970, and this was really useful. And we had the uh, classical irrigating cannula, and then we have the self-retaining Chalam lens, KV Chalam, and then we have the non-contact or contact wide-angle systems. Then you also have the vitrectomy machine, and this has undergone a sea change revolution. There's a breakthrough technology with the kind of cutters which we have, heavy cutters. The ones McMahon used was a single vitrectomy infusion suction cutter. So 20 gauge, 19 gauge opening. Now you have 23, 25, 27. So the, the fineness of the entry wounds have also decreased. So then finally the last two slides, I just want to tell you that we now come to 3D imaging, and you have the generative 3D visualization. So you actually have a 3D high resolution camera. You watch the surgery on the screen and then operate. So you're not looking into the patient, into the eyepiece. You're looking at the screen and operating. And the biggest advantage is not only do you have the screen but the IOCT. So you have the 3D Ingenuity device plus the IOCT going simultaneously with you. So if you want, you can do good work. And just show you one case that we did, and there's some mending with this. And so this is on Ingenuity, and there's a hole in the macula. Sometimes not very clearly myopic patients, so just put some tricot to make sure that the posterior vitreous detachment. Put some Orolab Brilliant Blue G, which I find extremely nice and very highly stains very well. The Orolabs are wonderful people. They're so helpful, and in Delhi also their office. So they give you such a lot of stuff, and very reasonable. So I wish the others in India could do something what Orolab's doing. And all thanks to Dr. B's vision. And she can put using the LM first, because there's a hole, you got to close the hole. If you don't close the hole, the RD has no value. So you got to take off the ILM, because the ILM is also a little stretched. So myopic patient, so myopic macular hole RD. So the IOCT actually tells you, besides the Ingenuity, the IOCT tells you, I make a paramacular retinotomy to drain, and that's it, finished. So of course, simulators will be there. Thank you. Sorry, I took a little extra time.
Thank you very much, sir. Thank you for that very, very scholarly talk, and giving the whole panorama of the changes that have taken place. Thank you so much, sir. We'll have Professor Mangat Dogra, sir, and Dr. Rajan Narayan to discuss the.
Thank you, Professor Atul, for highlighting what has happened in the last 20 years. And I feel the same. I think, of course, I think the biggest change has been the OCT and advances there. I think that changed the whole thing, the way we looked at everything, whether it is making diagnosis, monitoring these cases, and looking at the final. And another thing which I wanted you to mention, you didn't mention. Of course, you talked about them, about the anti-VEGF injections. I think that has been something which totally revolutionized. We have more people now joining us in the retina, because they feel that we can also do
imaging and VR surgery have scored over the anti-VEGFs. There's more of hype created about anti-VEGFs.
Exactly. So, but
anyway, there, I mean, Philip Rosenfield did bring in the Avastin, but.
Yes. So some of these things, I think, of course, we can keep on talking. You already said about these things. Since the time is short, I would not like to be here, but a lot of things have happened. And especially for, I would say at this time, surgical retina may not have progressed that much as perhaps the medical retina at this time. I think there was a time when we were very much, so you mentioned about the Ingenuity and other systems. So I think with this, I'll just hand over it to Rajan Narayan, because I think there's a limited time also.
Thank you so much, Professor Atul. I agree with Dr. Mangat Dogra over what has happened over the last few decades. I just elaborate a few points when it comes to Retina for All, overall theme of this topic which Dr. Partha Biswas has designed. there would be in the future also evolution, but transformative shifts in a lifespan of a career professional doesn't happen too often. Let's say 20 years ago, if you are a retina specialist in your career, you may have one or two transformative shifts of new technology. But what I see now is the product life cycle is getting shorter and shorter. The transformative shifts are happening more often. And I even tell my fellows that by the time they start their fellowship and end their fellowship, there are new terminologies, new technology, new OCD-based technologies or fundus-based technologies that they may get confused. In fact, the faculty in one institution may be using one terminology for something, and they may be hearing some other term, like ISO junction became ellipsoid zone. So what I'm coming to say is that while a lot of good things are happening, our basics have to be really strong. Our pathophysiology understanding have to be strong, and we have to be ready to unlearn, to learn new technologies, new treatment. This will keep happening in one career span now. Whoever is going to be a specialist now, they will see 3 to 4 times new things that they have to unlearn to learn. And that's going to be a challenge, and that's where we need to get training ourselves and also so that our fellows and future generations get trained. But overall, I think that was a very, very wonderful presentation. Thank you so much.
Thank you, Raja. Sir, any last comments you would like to make, Professor Atul, sir?
I'm sure the younger generation, which is hearing, and I'm sure they should get inspired by all of us leaders. And I mean, the IAVS leaders are here, the scientific committee leaders are here, you yourself are here. You're the biggest inspiration I see right now here, Partha. And you're a great friend of mine. And Prashant is here, he's a great inspiration in Nagpur. And there are 2 Prashants here. Raja's there at LVP, Lalit's there. And Professor Dogra, of course, is the doyen of Retina and ROP. He established Retina and ROP in India along with Professor Amod Gupta. So PGI has its, one of the leaders in India. So we should be proud of their institutions who've done so well. So Chetra is there from a very leading institution, which is really shining as the sun and rising fast. The Narayan Netralaya, and you see all the best candidates choosing Narayan Netralaya for their fellowship because it's very organized, and people like Chetra there, she's a very organized person. So they want to do their fellowships under her. So I feel good that there's so many nice people around that India is secure. India is secure.
Partha, I have a small comment.
Yes.
The next topic. Just because, I now am in the phase of life where I have seen the retinal surgeries from buckling to now vitrectomy. Atul and, Lalit, can you not agree with me that there are certain procedures which are now taking backstage just because there are advances? Now, I think vitrectomy is just taking over any case which could have been buckled easily. So probably the message when we are talking about the evolution should be that let's not forget the past. As new things are happening, Raja said, yes, we should learn new things, but do not unlearn good things. A single hole we used to buckle, I still buckle. Me and my son now, the new generation from Arvind, we have a fight whether we should go for vitrectomy in this case or do a buckling. So I just want a small comment before we can go, because
of course, buckling
is not always right. It's not always perfect. Now Steve Charles does.
I totally agree with you. I just said fluorescein is there to stay.
Yeah, it should.
And it's there, and everybody keeps a fluorescein camera. If he's doing a little bit of retina work, first thing he comes into his mind is having a fluorescein camera. It may have some added features in it, but fluorescein camera is a must for anybody practicing even retina for all. In retina for all, fluorescein camera is a must. And same way would be scleral buckling. Scleral buckling is one of the processes of curing a retinal detachment. Vitrectomy is there. So you got a vit buckle. Now, in USA, there's a vit buckle society formed by Dr. Rohan Lakhanpal. So, they've realized that vitrectomy and buckle combined is very effective. So there's a vit buckle society. I was very pleased to hear that.
Absolutely.
Dr. Lakhanpal, Vinod Lakhanpal's son.
I know.
See, Prashant, I agree with you. Buckle is not dead. And as Atul said, FA is not dead. And Raja very nicely said that although we should all keep abreast of the latest but you can't forget what is still giving good results. Like still today, a dialysis or a single break, which is buckleable, I think a lot of us
Yes.
still in a young patient would still like to buckle. Uh, Whereas like Octa is coming up, OCT is coming up, but FA is still not dead. People don't, see, we can't, most of us still do FA, although its proportion has gone down. You see, a lot of patients we do OCT and Octa, but still there is a place. The number of FAs we do has gone down by say around to one third or maybe one fourth, but still FA is still alive. So very nicely said by Dr. Atul. But two things if I have to point out in medical retina and two in surgical retina for take home is the imaging, the multimodal imaging in medical retina and pharmacotherapy, what Mangat was listing, have made a sea change in the management of so many diseases. And two things in surgical retina will be, to my thinking, is this new generation vitrectomy machines and the wide angle availability. Because when we were learning VR surgery, believe me, wide angles were, very difficult to see. We could not repair a lot of these giant tears and peripheral visualization was very difficult. And these new machines which have come out. So two things here, two things there have brought out a sea change. It has happened in front of our eyes, and we have seen the success rate jump. You see, macular hole, I still remember when I was in RPC, we hardly used to operate. I'm talking of, late 80s. But now it's a half an hour job, and most of these patients do pretty well.
Thank you very much, sir. Shall we go to our next speaker, and that is Dr. Manavjyoti Burman.
Partha, if you don't mind, can I take a leave?
Yes, sir. Thank you very much.
Thank you.
Sir,
Thank you.
Thank you, Atul.
Thank you for inviting me.
Thank you, Atul. Have a good day.
Thank you. Thanks, Prashant. See you soon.
Thank you. See you.